So welcome everyone to our CPCRN learning series. Today we have a slightly different topic. We are talking about the Canadian Primary Care Research Consortium. So this is a collective exercise bringing a range of organizations, including, so I will be representing the Canadian Primary Care Research Network. I'm Onil Bhattacharyya and one of the co-leads of the Canadian Primary Care Research Network. We have Ayat Salman, who is Operations Director for the Canadian Primary Care Sentinel Surveillance Network. Andrew Pinto, founder and director of both the Upstream Lab and the Canadian Primary Care Research Consortium Interim Board Chair, which you'll learn about in just a second. And Onil Bhattacharyya, member of the Canadian Primary Care Research Network Patient Council, as well as an interim board member in the consortium. So we are building on a conversation that we began in Quebec City with many, but maybe not all of you, where we looked at bringing three large organizations together and building a consortium. So the goal here is to strengthen the impact of research and innovation for people and communities. We'll go to the next slide. So a little bit of an agenda. So we're going to talk about these three organizations. So these are the acronyms: CPSIN, CPTIN, and CPCRIN. But we'll talk a little bit about these three organizations, their history, and why they're coming together. Then we're going to talk about the Canadian Primary Care Research Consortium, its structure, both the advisory board and the transition team. And then we'll talk about three kind of big pillars, and then open this up for discussion and discussion and the next steps in this initiative. So many of you were here in the sort of at the founding and the initial conversations about what we should do. And now we're going to give you a little more detail about an action plan for the coming year. We'll go to the next slide. So why are we doing these things? Obviously we are aware of the challenges in primary care. It's in the newspaper every day, issues with access, issues with attachment, issues with the health human resources across the country. And so as researchers, we are keen to solve this problem. We are keen to be part of the solution, but we have many challenges as researchers. So part of, there's a range of, if we think of ourselves as contributing to a learning health system and helping policymakers and providers and patients make sound and evidence-based decisions in their daily work, we have trouble contributing to that. Oh, thank you. I'll just take a second. So let me finish this point. We have trouble contributing to that in part because of the time that it takes to get a study going, the way funding works, the way our getting protocols together. The pace of research is very slow. And so that's something we need to think about how we do better. And part of that is having infrastructures that we can leverage to make our work more efficient. The second is we do all kinds of little studies in our province, in our own ways, and sometimes not being aware of what else is going on in the country and the world. And so cumulative learning is challenging in primary care. And lastly, the scale of our work. How do we go from a small pilot to a larger rollout, to provincial rollout, and to multiple provinces? That has been inherently constrained by many of the structures that we have that are built around universities and provinces. And here's an opportunity for us to expand. The last thing I'll say as well on this, and my apologies for not starting with a land acknowledgement, is to say that there has been lots of primary care research done with First Nations communities, and acknowledging that. And we've profiled some of it both in our meeting in November, inviting folks from Sturgeon Lake in Saskatchewan to talk about their experience, and more recently at a meeting in Vancouver where Norma Rabitskin from Sturgeon Lake talked about her experience, and where she talked about engaging with researchers in a constructive way to build programs that help First Nations people. So this consortium is committed to doing that work on a larger scale and really applying these same principles of efficiency, of relational equity, of cumulative learning within a place and across places, and to help many communities across the country in constructive ways. So I think it's just an acknowledgement that as a community, we are located on often unceded territory of many different nations, and that as a research community, we want to contribute to both reconciliation and improving the health of populations across the country through a partnership that will be part of this big tent we are constructing. Go to the next slide. So I'm going to hand off to Ayat to talk about CIPSEN. Go ahead, Ayat.
Yeah, thanks, Onil. So in this presentation, we thought that it would be interesting and important to show you what these three organizations have done. So as the Ops Director for CIPSEN, and for some of you who are not aware of what CIPSEN is, it's been founded in 2008, and it's received funding from the Public Health Agency in Canada. It was initially funded as a research project for chronic disease surveillance, and obviously throughout the years it has moved away from a research project and more towards a data repository. It federates again data. Right now we have 14 plus regional networks, and its headquarters, I would say, or central team is located at Queen's University, with all these servers also located at the Queen's Center for Advanced Computing. Again, we've supported multiple research studies using primary care electronic medical record data, and we continue to do so. For the Public Health Agency of Canada as being our main source of funding, as well as I would call them clients to use the data for research, as well as other principal investigators and investigators located in universities across Canada. We've been able throughout the years since 2008 to create standards of extractions where our data is actually extracted twice a year. It is processed, transformed, and made accessible through a secure research environment that was also developed by Simver, which was donated from Simver to CIPSEN, and we've been able to use that secure environment where my researchers access the data. And obviously, there've been a lot of research working groups within CIPSEN who have developed case definitions, which are phenotypes way of phenotyping diseases, and there's an update with regard to that coming out as a CIPSEN report this year. So there's been a lot ongoing since its inception in 2008, and a lot of these processes hopefully we will continue to use towards the consortium. Next.
Hi everyone, so my name's Andrew Pinto, and nice to see lots of familiar faces. I'm a family physician scientist based at the University of Toronto, and where Toronto is on now is on the traditional land of the Huron-Wendat, the Seneca, and most recently the Mississaugas of the Credit, and just want to acknowledge that. In terms of my role, I direct a team called the Upstream Lab and serve as the director of one of the practice-based research networks in Canada that's based at University of Toronto called UpLearn. And I'm here in the role of helping get started the Canadian Primary Care Trials Network, which I'm going to talk a bit about, but serving as the interim chair for the board for the Canadian Primary Care Research Consortium. We're going to, just to give you the heads up, we're going to move through these slides fairly quickly so that we have time, about 20 minutes at least at the end for discussion to engage you, because part of this is really to get your thoughts on how to shape the consortium as a new entity. The Canadian Primary Care Trials Network is much newer, I'd say, than CIPSEN or the Canadian Primary Care Research Network. It's kind of the new kid on the block, and it got started just a few years ago. And really, it's fairly straightforward. It's about building a network of primary care organizations across Canada that are able to support trials. And so these are our objectives: supporting primary care researchers to design, fund, and lead trials. We do things like workshops and learn and really training on trial design, and also even training on how to write a grant to get funding for a trial. We aim to standardize and really share approaches to make things more efficient across Canada, and work closely with other actors in the space that are trying to accelerate clinical trials in Canada. We want to support knowledge mobilization, so when a trial comes to an end and there's some lessons, really help make it efficient to bring that to guideline developers and providers and payers. And also really key is number 4 is be a point of connection to other trial networks and other investigators. So one of the most common areas of work we hope to do is collaborate with colleagues in cardiology, diabetes, respirology, and other areas who are interested in doing trials, but work with them, not just to be a source of patients for their trial, but rather to really work with them closely on, is this something really important, and how to translate the findings as well. So the Canadian Primary Care Trials Network is going to be a key part of a pillar that we're going to talk about around clinical research and clinical trials. Turn it back to Onil.
Thanks, Andrew. So the third group, so we've talked about CPCN and the Canadian Primary Care Trials Network. And so I want to say a little bit about the history of the Canadian Primary Care Research Network. So it was founded in roughly 2015. It was proposed at the beginning of the Strategy for Patient-Oriented Research. One of the first set of entities was these things called SPORE support units that provided methodological support in most of the provinces across the country, and they had a provincial focus. Then came a series of networks in chronic disease that really focused on diabetes, developmental conditions in children, mental health, and a range of things, gut and pain, as well as kidneys. And they were not based around provinces. They were multi-provincial, but they had, they didn't have representatives from every province. And so they had been funded and then renewed on a smaller scale, and now are kind of winding down. And around just after that, the SPORE Network and Primary Integrated Health Innovations were funded. And that did have, so every province got $500,000 plus a $500,000 match, with one sort of bucket for all of the territories. And that ran for 5 years, and then with 2 years added on. And in that initial structure, you had every province got funds, and then independently, CIHR got funds, and people from this broader network could apply for CIHR grants up to, at that time, it was 38 grants. And so that was the first phase. And over that time, we built a steering committee, we had a coordinating office, and the group started to gel, move really from a bunch of independent networks as a network of networks into something a little more cohesive. And we'll go to the next slide. In its next iteration, the Canadian Primary Care Research Network, we had one pot of funding, so $10 million with a $10 million match that went to a central group. And that group, the sort of network of networks in the previous slide, that group got together to write a big grant. And we had patients helping write the grant. We had committees to help determine how the funds would be allocated. And they went to 3 buckets. One, practice-based research and learning networks. Second, primary care information system, drawing on information from electronic medical records, patient-reported experience and outcome measures, as well as administrative data. And then we funded 8 different research projects. So this was already a sort of coming together from a network of networks to one big network that is distributing funds to all these 3 sort of broad initiatives in a much more elaborate governance structure. And we'll go to the next slide. So within this, one of the big investments was to provide funds to all the practice-based primary care practice-based research and learning networks, and you can see the list here. So there are a bunch, some of them forming, some of them already well established, and so funding was flowed to all of these groups to help them develop into to maintain them, but also move them along a sort of maturation pathway where they are better at collecting data, recruiting patients, running studies, and engaging in both research and quality improvement activities. And they're all kind of at different stages, but this is one of the big investments for the group. We'll just go to the next slide. In terms of numbers, and these are not all up to date, and there is a bit of a mix of, groups for which we have data and groups for which that, just participated in studies. And so practice-based research and learning networks do two of those things. They run studies and in some instances collect data. So you can see the range of different networks and the numbers. And so it's quite substantial when you add it all together. We'll just go to the next slide. So in the last 2.5 years, what have we achieved? So that $20 million investment led to $77 million in new funding for 113 new research grants, 292 articles, 4 books, 13 reports, 246 posters, and 123 oral presentations. We've supported these PBRNs as I've just described. 12 PBRNs provide EMR data to the repository at CIPSIN, which you just heard about that I had described. And as of September, CPCRN engaged 672 clinics covering almost 2,500 providers and collected data in various ways from over 2 million patients, 2.8 million patients. So there's a lot of activity in primary care already. And then one of the pieces that Shanil will elaborate upon is the presence of a national advisory committee, as well as patient involvement in the executive, steering, and all operational committees, and really something that is core to the network's activities. We'll go to the next slide. So we've got networks. We have 3 different networks. Why are we talking about consortium? So we think the consortium model will help us with collaboration and accountability. Research networks are pretty loose, and you give people grants, and then they do their thing, and then they have limited reporting requirements for CIHR and for other funders and for the contracts, but it doesn't have an elaborate accountability. So that's one element, that a consortium will work together more closely. We are going to have resource sharing among participating individuals and organizations to a greater extent. Much of the investment is to build a shared infrastructure, which we'll talk about in a minute. And we want to represent a wide range of stakeholders, so patients, providers, researchers, policymakers, and others. And the goal ultimately is to attract more diverse funding opportunities as we can demonstrate a unified, collaborative, and cross-jurisdictional effort in primary care research. That's the overall goal. We'll go to the next slide. Why now? So one of the more compelling reasons is we have 3 large networks that have overlapping mandates and many common people. Many of the people on this call contribute to these things and sit in different meetings with all 3 of these groups, and we're trying to bring that together. The other reason is we want patients and providers to benefit from primary care research faster. We want communities to be more aware of this research and its impact. We want researchers to roll their sleeves up and address the health challenges of Canadians more efficiently. We want government agencies to align with us, their policies, research policies, with this consortium, because we're big enough for them to pay attention to. And we want funding partners to provide growth-focused funding for research in primary care. We want to grow the pie for everybody. So the CPCRC will provide a unified governance structure for research to be conducted, disseminated, expanded, and drive policy in Canada. That's the goal. One of the things we've talked about is that we want the Canadian Primary Care Research Consortium to be a home for primary care research. And so we hope that in this home, you will find a place for yourself. This includes, at a high level, learning health systems as a strategy, particularly across provinces, governance and accountability, a united form of advocacy, or create a voice that can spread this. We have patient focus and citizen engagement as a core element. Here it's kind of at the base of the roof, but you could really think about it spread throughout the organization. And Ghislaine will share some thoughts eventually on how this, how we can represent that accurately. When you look at the areas of activity, you have centers of expertise on a bunch of topics. which are the research topics of everyone, on this call, and many others that yet to be determined, and that focus on patient outputs and impact. We've got the pre-BR lens that we've talked about as one pillar of activity. We have primary care research and clinical trials as another one, and data and analytics. And then on the other sort of large pillar is this strong academic, scientific, physician, and intergovernment relationships. So we are a large entity that can, negotiate and engage with national and international bodies. And then, supporting all of this is a training, education, and capacity building infrastructure. And at its core are a set of values. And the group here, particularly in CPCRN, but also the other networks, have worked, for several years now on a set of values. And this doesn't capture it perfectly, but we'll, refine that. But that, we'll be driven by those values as we proceed. This is the first stab at this. You've seen a version of this. We will continue to modify this, but this is the beginning, or I guess step, one of our co-building exercise for the consortium. We'll go to the next slide. And there are a number of people who will be part of this co-construction exercise, and we've listed them all here. Many we've reached out to, some we have not reached out to. There are groups like, First Nations that we've engaged on some level, but that we need to do much more work in. So this is kind of the beginning of that agenda, filling out the various rights holders and communities and determining what their role will be in this initiative. Go to the next slide. Okay, now I'm going to hand off to Ayat. Or actually, sorry, Ayat, should I take this one?
Yeah, either you or Andrew.
Okay, it's fine. I'll just wrap up here. So our vision is a home for primary care research to advocate, capitalize, and strengthen its impact with patients and the public. That's the core vision. Our purpose is to be a formidable research organization that speaks with a united voice to government, the public, and institutions for the good of all Canadian citizens. And our values, as we've mentioned, are courage, inclusiveness, trust, and transparency. And again, these are things we'll elaborate on further. And we have three sort of streams of activity that run across that: data and analytics, clinical research and trials, and PBRLNs. So I've already spoken a little bit to the PBRLN piece, and I will now hand off to, sorry.
No, I think I'm taking over. Yeah. So thanks, Onil. One really key item which is new is this consortium will be created as a nonprofit entity. So it will exist and continue and have a number of different funding sources, but not just be tied to a grant. So that's a big change from how CPCRN has functioned, and before that, how the SPORE entity. So we don't want to build something that when the CIHR grant comes to an end, then the whole thing kind of stops. We also, part of constructing this as a nonprofit is to have a group of people who change over time, who are helping direct it. And so this is the interim board, and I'm serving as the interim chair. But something that we will be doing is putting a call out for people to join, and also for them to elect a board chair. But just like any nonprofit organization, that there is governance at that level that does change over time too. We don't want this to be owned by any single investigator or researcher or organization in Canada. It's meant to be a consortium that truly is a home for people, and that changes, over time. So this is the interim board, and just want to thank all of the people here who have given their time. Shanil is on the call as well, and he's going to be talking a bit about the patient and community engagement aspect of this. And I can't see everybody here, but there could be other members who are joining as well. And then if we just go to the next slide, this is what we're calling our transition team. it's made up of staff members from different entities that are part of CIPSEN, CPCTN, and CPCRN, and they're acting to help get things started with Ayat as the interim executive director. I'm going to turn it back to Ayat to talk through what's been done so far and what's the plan. And again, we're we're going to conclude, to really engage you in questions and your thoughts on this. And really, this is meant to be something that's shaped with all of your input, but to serve, multiple different needs. I'm really interested, and just to kind of plant this, in the key things we do over the next 6 months that also demonstrate value, that it really is helping solve problems that primary care researchers and communities are facing. So over to you, Aya.
Thanks, Andrew. With our as leading the transition team and with our consultant Yvonne Bridges, we've set out some key milestones throughout the year. So this goes from January 2025 to December 2025. With some key milestones that we've already established in the Q1. So this really just gives you an overview of where we're going, what we need to do, and the roadmap leading us to the first year. I think what's also important in this slide is to understand that, again, the transition team are in their interim positions currently, and we are engaging with everybody to make sure that there will be a call out also for those positions as well around October, November. So we are really trying to engage the community to to come on board and also apply, and these are going to be called out. In terms of Q1, we've been able to get the first board meeting, as Andrew said, and we've got some first year budget approved. And as you've seen, and this is where our focus is today, we do have a communications plan that is completed. And really the idea today is really to engage all of you in the discussions. So we are looking for questions, and we are making sure that you are also engaged in the upcoming activities. So next slide. So what is the engagement that we're looking at? So we're really looking at, so when this was presented at the different steering committees in the different organizations, a lot of the word co-building came up, and we want to co-build this. So we've thought of the transition team, as well as the key founding members, have thought a lot about what would be the process to move this forward, and how can we involve everybody in this co-building process. So what we've thought is to have those co-building series sessions where we invite everybody. And when I say everybody, it could be people at the leadership position, it could be people more on the ground work, research assistants, clinical research associates, etc., and so on. So really everybody to attend these sessions. These sessions have already been sent out as an invitation to everybody. So just make sure that you've received the invitation, and we really push people to actually register and co-build this with us. Next slide. And this just gives you an idea of how we've done this in terms of timeline. So we have communicated with everyone. The consultations start with the first session being tomorrow. If more sessions are required, we will add more sessions as it's required. We will start revising, reviewing all of these sessions as they will be recorded, and we will be presenting all of this in a town hall at the end of June. Sorry, not tomorrow, Thursday. I'm already in Wednesday. So this gives you an overview of the different sessions, how they've been divided. Again, these are not set in stone. This is what we think are the discussions and the key activities that we've created for those sessions. If we think during a session that there might be another key activity that will require some more discussion, we will create a session for this. So the first session, which is governance and organizational structure, we do invite, again, everyone to participate, whether you're part of a patient council or a research analyst and you want to have your voice heard, we are ready to hear. And again, we're really pushing towards co-building. So this is Thursday, not tomorrow, sorry. Thursday is the first session, and you can still register for the session until tomorrow evening. Next slide. So what I'm trying to focus today is to get you thinking about the different co-building series that are upcoming. Some of those co-building series have been divided as per our streams that was presented previously as part of our organizational structure. So what I have in the next couple, actually next few slides, is some of the things that you might be thinking of, that we're trying to push you to think for, and to bring up during the discussions. There will be breakout rooms. All breakout rooms will have the same question, but I've kind of put out some suggestions in here. For example, in terms of activities that people can be thinking of, that can be bringing on board to the sessions, that would also be facilitated by Yvonne, and that can bring more discussions in towards more of that co-building process that we're thinking of. You can go to the next slide. The data and analytics pillar, we think that this is going to be a big pillar where a lot of the discussions are going to happen. And we think that there might be more registrations, and don't worry if there are registrations that are full, because we are looking for a maximum of 35 participants in each session. We will create other sessions and open up other sessions to have and continue those discussions. Data and analytics is a very big pillar. There's been a lot that's been done within SIPSN, and again, we're not trying to reinvent the wheel, but we're trying to co-build this with what we have. And some of these activities are, proposed in here that can get you thinking, might have more discussions, more pronounced discussions around, and we will be happy to bring in more sessions around a focus. For example, if one of those activities become a main focus of discussion during those series. Next. Another pillar in there is clinical trials, and as Andrew said, it's pretty new, and we want to hear more. We want to hear what people have to say about this, what they need, what they require. These are just some activities that we're proposing in there. It could be something that we can push further, or it could be more activities that might come up from our discussions. But again, we really need you to start thinking about how you want to move forward this pillar. Next. And obviously, this is an important pillar because, as Onil has mentioned before, we do have that across the home organization, and we want to make sure that this is developed. Now, we're not only inviting patients and community for this session. We're inviting, again, everybody. So does the other sessions. We are inviting patient community in the other sessions also to open up those discussions. And you can see in the chat right now, there's the links for the registration. So if you are willing to register now, you can follow those links. We'll be happy to send out again the invitation if required that was sent on Monday, just to make sure that everybody is receiving what they need. And Shanil will talk a bit more about some of the things that you may be thinking specifically for this session. Next. The other important aspect in here, as you've seen throughout the slides, there was a logo that was created by our amazing Chad. It's a great logo, but we had to go further and develop new logos. So we are inviting all of the community to actually complete a survey to decide which logo we should go for. So it is important to cast your vote. You have until Friday to do so, so that we can move forward and be able to hear what people think of the different logos. But we're happy with Chad developing the first kind of draft of that logo that we've used in this presentation, but there is more for you to start co-building also with that regard. Next. And very important, the one of the Q1 milestones that we were able to accomplish was the interim advisory board meeting, and we will be sending out the chair's letter for this advisory board that was set and happened in February 2025, and this should be coming out to all of you by the end of April, hopefully. So now I have to pass it to Shanil first before we go for questions. Shanil?
Shanil, we can't hear you. We could probably stop sharing the slides.
Can you hear me now?
Yeah.
Thank you, Andrew. I was saying my name is Onil Bhattacharyya. I'm from Calgary. I'm on the patient council, also an entrepreneur myself. And you'll notice, like, if you meet the patient council, we all come from diverse backgrounds in respect to profession, as well as where we're from, in the sense that we represent, we try to create a representation of all of Canada, including First Nations. And we met at UBC a few weeks ago, and as part of the consortium. And our goal as part of this consortium is really to co-build a structure, as you've heard. We see our role as to amplify the effectiveness and demonstrate value to individuals. Onil mentioned how primary care is in the news, and we see our representation there as a different voice, a different perspective. And so we're going to be embedded into different areas. And a bit about us, many of us have co-authored publications. We've written grants. We've screened publications for acceptance at conferences. And so we're versed in the ecosystem and the life cycle of clinical research. We also have access to our provincial counterparts to provide support in either advocacy of the consortium, but also in specifically with when it comes to specific clinical research. I see our role predominantly is creating awareness in the community, and especially with citizen engagement, and then also advocating and ensuring that this process is transparent to patients and caregivers. I do want to say that at the meeting in Vancouver, Sabrina Wong was there to talk about the consortium and the big vision. I felt, and the group felt, a genuine receptiveness and request for the patient council to be representative and develop in this consortium. And I would like to leave with that, is that we feel the ask for our contribution is genuine, and that we will be put in a place of influence. So I want to say thank you, and we will continue working with Consortium over the year at the different touch points. Thank you, Andrew. I'll hand it back to you.
Thanks, Shanil.
Or Neil.
Yeah, I think now so you got a flavor, right? We have 3 different entities coming together to build a consortium. We have a patient advisory group that is going to inform that, but also be, participating in every level of activity of that consortium. And the other thing I wanted to come back to is the point that Andrew made, that this is actually a nonprofit, right? So this is not a research grant. This is a new organization that we are building together. And obviously all of you sit in research departments and clinics, and you have your own, you're not leaving the organization that you're part of. But there will be situations where flowing money or doing something through a nonprofit will be advantageous. And that's, part of the, the value of this structure. Shelley, why don't you kick us off?
Great. Hi, everyone. I'm Shelley Doucette from New Brunswick. I just wanted to clarify. So you had mentioned that the positions that are currently interim roles will be filled. I'm curious to know what the selection process will be in terms of deciding who will fill those roles. And also, you had just mentioned that it's nonprofit. So would they be unpaid positions, or what will that look like?
Yvonne.
Hi, Shelley. I'm Yvonne Bridges. I'm the consultant who's helping with the strategy and a number of things like this. So there will be a call out. It will go out to as many people as we could possibly reach. And there will be a link on the website for applicants. Then there will be an interview process. So then from the people who apply, we'll narrow that down. We'll have an interview process. And then the individual chosen will receive the opportunity to say yay or nay. The positions will be paid. We are still working on budget. I'm not going to hide that piece from you. We're working on those pieces. So as soon as we have all that information, we'll share it as well. But it will be an open call, and anyone who believes that they're right for the role as it's written and shared will have an opportunity to apply. So it will be very open. We'll have a group of people who come together who do this in a very strong process-driven approach. So people are clear about how the outcomes are arrived at. Did that help you?
Yeah, so just to clarify though, who is actually doing the hiring? Like who is doing the interviews, and who would be the one selecting who gets hired for these roles?
Right, so that will be a committee, and we don't have that committee struck yet, but we will strike a committee. So I don't have the answer to exactly who will do that. The roles themselves will be hired from CPCRC. So once we have the not-for-profit corporation from the federal government, because we're doing a federal NPC, then that's who will be doing the hiring of the individuals and the roles. Does that help you?
Yes, thank you.
You're welcome.
Okay. Other questions from the group? And, it can be broad and philosophical or very operational, just like Shelley highlighted, which is
Neil,
welcome. Yeah, go ahead, Amanda.
just a quick question. Would you like these invitations for the consultation sessions to be circulated in our own networks? Is that something that you would? Okay.
Absolutely. Yeah, this is a big tent, right? This is not a grant and not a guest list only kind of situation. We are building a consortium with the primary care community. So share with anyone you like.
Great.
So just to add to that, Amanda, what we've done in the transition team is we've gone through our MailChimp for each organization, and we've got them all together, what we had in terms of our mailing individuals, and it came up to about 500 people between 500 and 600 people in our list. Now we may be missing people. If we are missing people, do let us know. Maybe Manuela, you can post that email, the general CPCRC email in the chat. If you haven't received it, received the invite. The invite, unfortunately, depending on your email address and where you're located, it might be found in the junk. So I highly recommend to go and look through that and make it like something that you'll get in the inbox, because you will get a lot of the communication through that process. But again, if you think you did not get it, happy to email us and we'll add you to our list in there. We worked really hard to try to bring everybody through this list, but we're happy to add more in there if we're missing any.
Jane, go ahead.
Just so I'm clear about this, no one will be paid anything until after the not-for-profit corporation is established, and you've got like everybody who, like, let's say the executive director, we have an executive director, or did I misunderstand that? I mean, we have an interim executive director now. Normally an executive director gets paid.
Right.
So is this person being paid, and if so, by whom?
So at this moment in time, Jane, the interim executive director is being paid by Queen's University in her role there. She's done much of this from the side of her desk. We're working on an agreement to get her a bit of a top up, but that's it. Same thing has happened with Chad Herman. He's also working as part of SIPSN, but in his role as interim project manager. We also have made an agreement to get him a small top up, but nobody is being paid, not a single person is being paid a full-time salary for anything yet. That includes the board. They're all very aware of that. Andrew can speak more to that. And there's a question in the chat that Andrew will also answer. But fundamentally, we're just working hard to get this off the ground.
Okay, thanks.
You're very welcome.
Thanks. Yeah, the interim board members are all volunteers, including myself, and so we're not being paid. When we have patient partners or community members, we sometimes provide a very modest kind of honorarium just for their time. It's I think a decision that we'll make of whether the board members would be paid. Usually in Canada, we usually don't do this, like particularly for nonprofits, but in research, much of our salaries are paid by universities or chairs that we hold or things like that. And then there's a question from Denise about the governance model and strategy, be able to operationalize the new strategy for people-centered, partnership-oriented research as well. So I think the answer is yes. You know, what we're doing with this consortium is actually moving it to be able to adapt with changes to strategies like this. So we want it to not be so focused on one time period from, say, the Canadian Institutes for Health Research. We want it to be an ongoing, adaptable framework. I think something very key to primary care research is being patient and community-oriented in the type of work that we do. And so, yeah, I think it will certainly go beyond the strategy as well. I think this is a great opportunity for primary care research to lead the way and in Canada and beyond for setting up entities like this, and to actually really demonstrating how powerful it can be when you have community and patients really aware of what you're doing and really helping direct it. The other thing I'll just mention before we go to Sandra's question is that this is such a crucial time in Canada right now to figure things out in our country, how to do things efficiently. We all are seeing, you know, what's happening, in terms of working to reduce barriers to trade within Canada. And the same has to apply to research. It's ridiculous that we spend so much of our limited research dollars on these barriers that we have created in our own country. So this consortium is coming, I think, at a really good time. And we want to capture this moment when governments are actually motivated to break down barriers to working across the country and to really making us a world leader in primary care research, whether it's trials, whether it's data science work, whether it's helping advance research that's going to improve things in other countries as well. I'll turn it to Sandra for your question.
Thanks, Andrew. I don't know you. We were at an event together, but I know all about you and your connection to patient partners and community, and I think that's great. I'm a patient partner. Also, I think it's great that you're all coming together. There's nothing about silos. I get really frustrated, especially in research, when we're not doing things, we're just doing things by center. So I think this is excellent. I look forward to seeing, I'm not sure if you've already worked with patient partners going forward. There was a slide that was saying about, would be almost like what you would do with patients, but it would also be, you're using the word co-build. I would like to be able, if you could use co-design, especially if you communicate, including other patients and community. And so, yeah, I definitely wanted to know if you've already involved patient partners too, so far. And I've already registered for your course, and I'm a member of PAN, Patient Advisors Network Board, and I've shared it with them as well. So I just wanted to say congratulations to all you for doing this and coming together. And I think it's very important because the most effect we can make for patients and caregivers and primary care doctors is from primary care doing research. And there's a lot of things that we could fix, and even like PREMs and PROMs, like just getting that implemented. I've heard so much about it, but I haven't been anywhere where it's been implemented and used. So just wanted to say thanks for all the great work you're doing.
Thanks, Sandra. I want to shout out to the Patient Advisors Network. For those of you who are not familiar with them, they are a very effective group in terms of their ability to engage in research, to work together as a large group and as individuals within projects. And I think they're close partners for many of us. Any other questions? Just checking the chat. Yeah, go ahead, Arif.
Arif, I think you just have to unmute yourself.
Okay. First, thank you very much for this informative session. Thank you very much for all of you. And I have two questions. First, supporting research is very important. I think that it is what you are doing. But my questions is one before the research and the one after the research. The one before the research, does any of this organization have a list of the most pressing issues that needs to be studied in terms of the primary care? One, and concerning the after research, does any of these three organizations have a specialized team that work in terms of transforming the findings of this research in collaboration with the decision makers to transfer them into policies and the procedures?
So great questions, Arif. I'll maybe take them, have a first stab, and then Andrew and Ayana or others can chip in. So on the strategy, like what are the priorities for the network? We've not established that thus far. I think part of it, what you've seen is like these are three pillars. These are like an infrastructure. And then the subsequent exercise would be, okay, what do we work on? What is a big, what are our priorities? So think of that as kind of a next step. With respect to how do we connect to policymakers? So we've done it to some extent as at the Canadian Primary Care Research Network. We have policymakers, particularly from Ontario and BC, that sit on our steering committee and provide input. And many of us as individuals have strong connections But to say that we have a coherent and effective approach as a network or consortium, I think is still to be done. That would
Yeah,
be
I
sort of-
think that needs to be done because if the findings of this research doesn't transferred into policies and the procedures, I think that that the research becomes a waste of money and effort.
Yeah, absolutely. So I think, what to study is a kind of core part of the patient-oriented research agenda, and one that, we are, I think, I won't speak for the group yet, but essentially is an important next step. And then how do we connect effectively with policymakers across regions, again, is another big part. Okay, I'm going to give Selena the last words.
Thank you.
Thank you, RF. Go ahead, Selena.
Hi, thank you. This is a really good conversation, and I just wanted to reiterate what Arif said a little bit earlier, and I think it's so important. I don't know if folks on this call have reviewed the SPORE refresh document, and that report actually highlights exactly the similar concerns that were raised. And I myself am a knowledge broker and implementation support practitioner for one of the SPORE chronic disease networks, the Kidney Network Can Solve CKD. And one of the challenges that we have found is that we've created this, we've done the knowledge generation, we've refined the evidence based on patient priorities, and we have these interventions, right? Like ready for implementation, scale, and spread. And the SPORE report actually highlights exactly the same frustrations that we have, is that evidence is often not implementation ready, and largely because it's probably not relevant to the policymakers and decision makers, or they're not understanding it. So I think it is so important to very quickly move that evidence into healthcare transformation. And how are we going to do this? We need these partnerships, right? We need these collaborations. Our patient partners need to be advocates with the researchers to translate some of these documents to align the priorities also with these health system priorities. But it's such a messy area, and I don't think researchers really understand that space as well. So these are very similar frustrations, I think, that we all feel. And it's nice to know that we're all thinking about it. I mean, our solutions are going to have to come collectively as well from this group. So I really appreciate this conversation. Thank you all.
All right, thank you, Selena. I think we obviously want to engage with all of the sport community that's been thinking about this for many years. And so to maybe come back to RF's comments, I think we want to figure out how to create an effective infrastructure to do research in a timely way. Then we need to ask ourselves, what are the important issues that we want to study? And then how best we study those, and what are the partnerships that will allow us to accelerate the work? So Selena's point around what the output looked like is essential. All right, we are at time. I want to thank you all for joining us today and being part of this exercise. Ayat has outlined a series of workshops that are coming, fast and furious. These are your first chance, but there will be other chances to get your input in. But we are hitting the ground running, and we are excited to have you all along for the journey. Have a wonderful day, everyone. Bye-bye.